mental disorders in children with congenital heart disease. And as Cecilia said, I'm a psychologist here, and I work only in cardiology, which is great because I get to know these children and their families really well. So this is my last minute insert slide, just to let you know that I have no conflicts associated with this presentation. So what I'd like to do over the course of, I guess, the next half hour or so is talk a little bit about why developmental assessment is important for children, infants, children, and adolescents with congenital heart disease, describe the risk profile, and then talk a little bit about what assessment involves at each of the important time points. So in infancy, school age, and in adolescence in the transition years. And while I'm doing that, talk about some of the concerns that have been identified in each age group. So why do we need to look at how these children are doing? Well, the biggest reason is that we know that there's been a tremendous change in mortality rates for infants with congenital heart disease, dating back to the 1970s, for example, when most children with critical congenital heart disease would not survive. We're now at a stage where there are actually more adults surviving and thriving with congenital heart disease than there are children. So the mortality rates have greatly improved. What's not improved, however, so much are the morbidity rates, despite improvements in our knowledge and in surgical techniques and so on. There's still neurodevelopmental anomalies are the highest morbidity for these children. And we know that congenital heart disease is a very broad category, and there are many different levels of severity. And while it's true that children with congenital heart disease who have some sort of a genetic syndrome or who have the most critical forms of congenital heart disease are at the highest risk for neurodevelopmental issues, it's also clear that some children with milder conditions also show neurodevelopmental impairments. So there is a need to do at least some sort of assessment for the majority of children. And in fact, it's this knowledge that provided the background for, in 2012, a scientific statement put out by the American Heart Association and Pediatrics, talking about neurodevelopmental outcomes in these children and also how they need to be managed. And the biggest recommendation is that there needs to be a tiered approach to working with children with congenital heart disease. So starting with developmental surveillance, which was recommended for all children. So basically having pediatricians ask families how their child was doing in different areas of development. Above that is screening, so getting parents to complete questionnaires that focus specifically on development. And then the highest, those at highest risk, or those who were showing the most significant problems, would be referred for a much more thorough, in-depth neurodevelopmental evaluation. So these recommendations came out in 2012. In 2012, there were very, very few formal cardiac neurodevelopmental programs. And since the publication of these guidelines, there's been a tremendous increase across North America, across Europe, and we have our program here in cardiac neurodevelopmental follow-up programs, where really the development of these children is very closely monitored with the hope of providing them with early, targeted, and timely interventions. And that's also resulted in a huge amount of research on neurodevelopment and the formation of organizations dedicated to looking at development in children with congenital heart disease. So the field has grown tremendously just over the course of the last 8 years or so. So initially, when the guidelines came out, the recommendation was that infants be closely monitored at about 9 months starting, and then 18 and 30 months or so. Then when they entered school, that was viewed as another important transition during those early school years as well, and then I guess through to adulthood. But even since the publication of the guidelines, there's been increasing awareness that really this isn't enough, and that children do need to be monitored at more time points, especially between the early school entry and the moving on to middle school or high school. There are lots of changes in learning demands. And there's a concept that these children grow into their deficits. So, children may show certain weaknesses early on, but those weaknesses may change a great deal when they get into school and look very different. And also some children who do perfectly well in infancy and the early school years may not show weaknesses until they get to those middle school years where the demands are much greater, and they change as well. So in terms of risk factors for poor neurodevelopmental outcomes, so initially there was a lot of focus on what is it that's being done to these children that results in their showing poorer outcomes later on. So there was focus on looking at preoperative variables, operative variables, so length of time on circulatory arrest, the duration of rewarming, the cooling time, so on. Then they looked at factors after the surgery. So did the child have seizures? I mean, that is an important factor, but they were focused on things like seizures. Did the child need ECMO? When did they need a reoperation? And then looking also at genetic factors and the single ventricular physiology, lengths of stay, and so on. But really a lot of these risk factors, or certainly a lot of the surgical risk factors, didn't seem to impact outcomes. And the research that's been being done more recently, so I'm going to go back one, and much of that is being done by Mike Seed here, Stephen Miller, who's our head of neurology here, has shown that the risk for adverse or neurodevelopmental outcomes for these babies actually begins prenatally. And that children who are born full term with complex congenital heart disease have brains that are very similar to babies that are born 4 to 6 weeks prematurely. So white matter injury is something that's most often seen in infants with congenital heart disease. And there's evidence too that these babies are born with an immature brain, and this makes them more vulnerable to injury during the perioperative period. And we also know that although these sort of early vulnerabilities make children at higher risk for experiencing neurodevelopmental challenges, the profile of risks, the profile of things that put them at risk changes from birth throughout childhood and adolescent. And as they get older, the role of patient factors, of family factors, and other environmental factors also add to the burden. Increasingly, there's being a lot of attention paid as well to the impact of early experiences, particularly time spent in the cardiac intensive care unit or the pediatric intensive care unit, because there's increasing acknowledgement, and this comes from a lot of the neonatology literature, that these babies are exposed to an abnormal environment. There's a mismatch between what a baby expects to happen and what they actually get. So being exposed to all these wires and noises and lights and not being able to bond appropriately with parents has an important impact on the development of these babies. And increasingly, sites are incorporating family integrated and individualized neurodevelopmental care in the hopes of supporting outcomes in these babies. And if anybody works in the CICU, and I don't know if you've heard Vanna Kazazian speak to you yet today, but there's a program that they've brought in and are working really hard to include families in the care of these children. And this will hopefully improve many aspects of neurodevelopment. So what do we know about early development in babies born with congenital heart disease? We know that deficits are apparent very early on. The single ventricle reconstruction study, which was a huge study of children born with hypoplastic left heart syndrome, found that 47% of infants in that trial required some form of developmental support in the first year of life. And in terms of the types of deficits we see, most often in the first year of life, gross motor deficits are apparent. And there are many factors that can contribute to those delays, including just restrictions on the positioning and how they're able to be and how they're able to move about, and increased time in the hospital and lack of opportunities to develop their gross motor skills. But what we also know is that gross motor skills begin to catch up at around 12 months of age. So at about that time, or certainly by about 2 years of age, those deficits really are not as apparent. But what does become more apparent are fine motor delays And those types of delays actually tend to persist and impact on functioning at school that I'll talk about in a minute or so. The other delays that we see early on are delays in language production. There's also an oral motor component in the language production, and those oral motor delays are also seen in feeding difficulties, which obviously poor feeding will impact neurodevelopment as well. So I've just put this up just to show an example of the kinds of problems, the kind of red flags that we can see in children that are seen in children with congenital heart disease. So at 12 to 18 months, we would expect infants to be walking, to be speaking in single words. But some of the red flags would include being slow to walk, not speaking, extreme fear in new situations. When a child enters school, we expect them to be fully coordinated, to be speaking in full sentences, to show school readiness in terms of understandings of letters, numbers, shapes, and so on. And what we often see in children with congenital heart disease is that they're having problems learning letters, poor coordination, that's the fine motor skills in terms of being able to do zippers and snaps, trouble playing with their peers, so there are some social aspects, and poor pencil grasp and difficulty actually forming their letters and numbers. So here at Sick Kids, we do have a cardiac neurodevelopmental follow-up program, and we start seeing infants at about 18 months of age. And when we see infants at 18 months, the gold standard way of looking at development is using the Bayley scales of infant development. And we are currently using the 3rd edition. We've just recently moved to the 4th edition. This is a measure that goes from birth to 42 months of age, and it looks at 3 domains of functioning in children or in infants. One is cognitive, so looking at problem-solving skills, and I'll give some examples in a minute. Then we also look at developing receptive and expressive language skills, and initially that's just things like responding to sound or cooing and so on. And motor skills, both in terms of the fine motor and the gross motor component. So the Bayley is, I've got a picture of it here. It's a play-based assessment because that's how children learn. They learn through play. It's very interactive. We get parents to help us when we administer the assessment because children obviously at that age are much more comfortable with their parent around. And the items are used to look at different skills and different ways of doing it at different ages. So the same task could be used at different ages. We just have different expectancies for the child. The important thing about infant assessment is that, especially at the early ages, infant assessments are not predictive of how a child is going to do when they get to school. It's not even predictive of how they're going to do in the next month or so. It really gives us a snapshot of how they are doing on the day of the assessment. And it's important to have that snapshot if it's a valid one, and parents help us with that, because that helps us identify where the child may need early intervention and helps us target that so that they can get support as quickly as possible. And we know that it's important to intervene early because early intervention does work and it does support development in a number of different areas. So this is the Bayley being administered. As you can see, mom is helping a great deal. Child is on her lap. And the time it takes to administer the Bayley is going to depend on the child. It typically takes about 30 to 45 minutes, but if you've got a child who's hungry, who's tired, that can go on quite a bit longer. And here are some of the items. So one of them is the pegboard. The child has to place a number of pegs in the pegboard over in a certain amount of time, and that time varies depending on their age. Same with the form board, it's just placing those circles and squares in, and we look at the number and the time, again, based on age. And for the youngest kids, all they have to do literally is take, for example, a peg and try to put it in one of the holes. It doesn't even need to have to go. It's just showing that they understand that function. So in terms of the areas, the gross motor tasks look at large muscle movements. So we get the child to roll, to walk, to run, to skip. Fine motor ranges from holding a bottle to picking up a little Cheerio and putting it in a container. Receptive language looks at understanding of sounds or directions. And then expressive language, again, we start with gestures, pointing, and then we go to sounds, words, and full sentences. We look at early thinking skills, so cause and effect. If we take a toy and we hide it under a towel, will the child know to remove the towel? We also look at social emotional functioning and how the child expresses and controls their emotion and their ability to calm themselves, be calmed, their ability to stop or start activities when doing them, when asked, sorry. So as I've said before, the Bailey is not predictive, but it really is important to help us with early identification and early intervention. And oftentimes children need either physiotherapy, occupational therapy, speech language support, or feeding support from a dietitian. But what we do know about early intervention is, one, that it works, but the problem is that research has shown that of all the kids that are referred for early intervention, about only half of the children actually go and receive it. So it's really important for us to try and figure out, why are these children not getting to a program even though they've been referred to it. And there are many things that could impact on that, but one of them is perhaps, especially early on, parents feeling so relieved that their child is alive and developing that they don't focus on anything beyond the initial medical crisis, and they don't place as much importance on development. So talking to parents about that, about the importance of some of these early markers and how it could impact their child later on, would be important. And then it's important for us too to look at other barriers. Are there language barriers? Are there transportation barriers? And try and figure out why these services aren't being accessed, because these are services that actually do support children and do make a big difference as they're developing. So I'm going to move from early infant development to the child now at school. And if you think about it, a child with a complex congenital heart condition, when they move to go to school, may have had multiple surgeries, may have spent a lot of time in hospital, limiting their ability to interact with others, may have activity restrictions, need medications, be tired, and have developmental delays. And the family also brings things with them at that time, including continued worry and fear that lasts, doesn't go away, uncertainty about their child's medical condition. They may have job stress or financial stress, and just caring for a child with a complex medical condition does disrupt family and social functioning. So these are all sort of a burden that face the child when going to school. And when we look at how children are doing with congenital heart disease, it's clear that they are at a disadvantage. So this data is from the United States, but it's pretty similar in Canada. The incidence of learning disabilities for all children is about 6 to 10%. But if you look at the estimated incidence for children with complex congenital heart disease, it's much, much greater. Similarly, students rarely repeat grades. Schools don't like it. It's just not a policy, but in students with congenital heart disease, it's double to triple the rate it is for other children. And there are estimates that about 50% of students with congenital heart disease need some form of special support in the school, which is significantly more than for children who do not have a congenital heart condition, who are born healthy. So I just put this up to really show in a striking way the difference between the two groups. So in trying to figure out why children are struggling at school, some people have looked at IQ, but what the research has shown is that, with the exception of children who have some sort of a syndrome or a genetic abnormality, most children with congenital heart disease actually score within normal limits on measures of intellectual ability. They typically have weaker nonverbal IQ scores, but again, still within normal limits. So nonverbal IQ refers to visual spatial skills, reasoning without language, appreciating puzzles, that kind of thing. And verbal IQ tends to be within the average range. So clearly we need to look at more than IQ. And a number of other components of cognitive functioning have been looked at, and weaknesses have been identified in a number of areas, including visual spatial skills, visual motor integration, language, attention, and executive functions. And weaknesses in any of these areas, and oftentimes they're combined, do have an impact on academic achievement. So I'll talk about some of those, some of the most important ones. So the most frequently identified weakness is in visual motor integration and visual spatial skills. So in addition to referring to how you copy things, it really refers to how do you see the relationships between parts. So how do you see letters in a word, for example? Are you able to discriminate between spot and pots? And as I said before, the visual motor integration or the eye-hand coordination is needed for writing, copying material from the blackboard. And children can have difficulties with just the perceptual aspect, which I talked about in terms of how you see things, how you see relationships between parts, just the motor aspect, or integrating the two together. So it's really important that we look at where those weaknesses are in terms of determining what kind of support they need. I just got a slide. Is anybody? Okay, there we go. Okay, so this is one of the tests that we look at to look at how the child is, the child's visual motor integration skills. So as you can see, I think this was a 9-year-old. So this is really, really below average in terms of how they are integrating information. They certainly can't do that. But even the motor coordination here is poor. And the perceptual skills seem to be pretty poor too. So this looks like it's a weakness in all 3 areas. But what we do is we get them to copy the designs. We also get them to match designs. So we'd show them that top figure and a whole series of figures that are very similar but different in certain ways. And all they have to do is pick the one that's identical. So that would look at visual perceptual. It's a matching task. And the other thing we do is we show them the shapes. And it's with dotted lines, and they literally have to trace the shape. So that looks at more coordination skills. So we look at the visual motor integration, the visual matching, and then the motor coordination. Another task that we give, and again, if you spoke to Vanna, she asked, if you've listened to Vanna today, she asked to show this as well. So you may have seen this figure already. This is called the ray figure. And it's a complex design. It's also novel and it's abstract. So it's unlikely that a child would have ever seen anything like this before. And we are looking for a number of things when we ask them to copy this design. We're looking at what it looks like, but we're also looking at how they approach the design. So the mature way, or the best way to approach this would be to appreciate that there's a big rectangle, draw that first, then maybe draw an X in the middle, and use those as anchors to draw the other parts. But a child who has trouble with planning and organizing spatial information won't be able to do that. So this is what we got from, I'm trying to think, I think this was a 12-year-old. So you can certainly recognize the design, but this would not be a strong score. And the other thing is that if you look at it, you can see that he really didn't appreciate the fact that there were these big anchoring components. So for example, that diagonal line was not drawn as a diagonal line, it was drawn as separate pieces. And he maybe put quadrants in, little pieces of the design in separately rather than draw the bigger ones and then use that to anchor the smaller pieces. So the reason that's important is because when we take away the image and ask him to draw it, this was all he was able to remember, because the burden of taking a piece by piece by piece approach is much harder than taking an organized big chunk approach. So that's what we got when we simply just took the picture away and said, okay, now you draw it. And then we did a whole bunch of different tasks, reading, spelling, whatever it is that we do. And we said, okay, remember that funny picture we showed you 20 minutes ago? Draw as much as you can remember. And this is what we got. So really, planning and organization, if those skills are weak, that's going to impact on the ability to process information and to learn it. And we see that at school a lot. So I talked a little bit about the impact of visual motor skills, and the impact on learning starts at the earliest stages. Because if you have a child, for example, who doesn't remember what the letters look like or can't form those letters, when they're in kindergarten in grade 1, they're going to be spending so much time trying to remember what a letter looks like, and the process of just that process of writing is going to be so effortful that that's going to take their attention away from what the teacher is saying, and they're not going to be processing the new concepts that are being learned. So we sometimes suggest really simple strategies for children in grade 1, asking a teacher to put a letter strip and a number strip on the child's desk so that they can have easy reference, and they can just look there when they need to remember what a B looks like as opposed to a D, and they don't have to be searching around the room to see what those letters look like. Or we'll ask teachers to give a child handouts so they don't have to be copying madly from the blackboard. They can just listen to what the teacher's saying and they'll have the notes there. So simple strategies, but we do have to identify where the problem is first. Okay, in terms of language skills, there's some research that suggests that children with the most complex conditions do have weaker language skills. But what's more important actually are more complex language skills in terms of the ability to make inferences when you don't have complete information and understanding ambiguities in language. So things like, you know, a simple thing is, you know, if somebody says, I'm so hungry I could eat a horse, it doesn't mean they're going to actually eat a horse. It means that they're very hungry. So children with congenital heart disease tend to think in more concrete terms and have a more difficulty understanding humor, for example. So that the difficulty in understanding more complex language doesn't only impact on learning in the classroom, but also impacts on social functioning in the playground, especially as they get to grades 4, 5, and 6, when those sort of play on word kind of jokes are much more prevalent, and you've got a child who's not getting it, who's being concrete, and who's responding in what their peers would perceive as a kind of funny, unusual manner because they're not getting the joke. Oftentimes, weaknesses in attention and concentration are spoken about in children with congenital heart disease. And yes, it's true that children with congenital heart disease are more likely to have attention difficulties, and the incidence of ADHD is considerably higher. However, it's important to not jump automatically to, oh, that child has an attention deficit disorder, because there are many other things that could explain poor attention in the classroom, including learning difficulties, which result in frustration and struggles at school. And also knowing that children with a complex heart condition may have less energy to put towards attending and concentrating. And they may have lower energy levels at the end of the day, at the end of a full school week, and that may result in their fidgeting, but not being disruptive. So a quote that I found from a child with congenital heart disease, I think explains that better than anyone else could. Basically says, when I'm not paying attention in the class, it's often because my heart is not sending out enough oxygen, not because I'm being bad. I wish that you would know the signs so that I wouldn't always be getting into trouble. So this really highlights the importance of good communication between parent and teacher, so that they really, most teachers don't understand what congenital heart disease, what the implications of having congenital heart disease has on learning and on behavior in the classroom. So having that conversation is really important. And then finally, the area I want to point out is executive functioning challenges. And executive functions are interrelated functions that are responsible for purposeful, goal-directed, and problem-solving behavior. And these are functions that really develop as we grow. Some adults don't have fully functioning executive function skills. And there are 8 pillars of executive function that are recognized, and that's the ability to inhibit impulsive responding, to be flexible and transition between tasks, and to be aware that maybe your approach isn't working, you need to try something else, to initiate tasks independently, to hold multiple pieces of information in working memory so that you can process it and learn, to control your emotions appropriately, to plan and organize your approach to tasks, which we saw with the Ray figure, to organize your own materials appropriately, and to monitor the impact of your behavior and actions on others and know where to change it. And there's increasing evidence that executive function skills are impaired in children with congenital heart disease, and that the impairment in executive function skills actually persists through early adulthood and later adulthood, and really has continuing impacts on the functioning of these individuals in terms of completing school, securing a job, being able to hold on to a job, and social functioning. I've got some examples of executive function weaknesses here that parents would report. So getting stuck when solving problems, knowing solution isn't working, but can't figure out a different way to do it. Not being able to remember material that they've studied at home. So getting bad grades when at school, and then that turns into tummy aches in the morning and not wanting to go to school. So it can have really important impacts. And apart from the early developmental and academic issues, behavioral issues are also talked about in children with congenital heart disease. And I'm not going to spend a lot of time on this, but I will talk about it, I guess, next semester. Talked about attention and hyperactivity, but there's also evidence that children with congenital heart disease are at higher risk for experiencing more internalizing behavioral symptoms related to anxiety and depression, especially as they get older. This could be related to an increased awareness that they're different, that they have a medical condition, worry about potential further surgery, maybe being bullied and teased about being smaller, having learning challenges. And there's a lot of evidence, or increasing evidence, that these internalizing behaviors, or in general behavior problems, are not necessarily related to illness severity, but more related to perceptions of illness severity and how they are treated by others. So that's something to be aware of and something to pay attention to. So when we assess children here at Sick Kids, and I guess in any neurodevelopmental follow-up program, we really want to try and not only identify the weaknesses, which are obviously important, but we also really want to identify those green light areas, which is where the child is performing appropriately for his or her age. And this doesn't have to be an academic strengths, but it really is important to identify strengths as well as weaknesses, because this is what you can use as leverage to engage the child, engage the family, and help motivate and support their overall development. It's increasingly recognized that early assessment is important, and that this assessment must be repeated because of how the deficits change. As I mentioned earlier, early intervention is critical. We also need to pay attention to parent mental health, because parent perceptions impact on how they're going to treat their child. Parent perceptions of themselves and of their child will impact on how they treat their child. Sorry, I just went ahead very quickly. There we go. And we need to partner with the school to address all the factors that might impact on learning, and help teachers understand why these children are at risk and what kinds of support they might need. So just in terms of further information for anyone who's interested, As I mentioned before, this increased focus on neurodevelopment has led to the development of organizations that focus on neurodevelopment, and one that Sick Kids is a part of, and that anybody at Sick Kids can have access to, is the Cardiac Neurodevelopmental Outcomes Collaborative, or CNOC. They're cardiology special interest groups. And here at Sick Kids, we have our own cardiac neurodevelopmental follow-up, and it's a lovely collaboration between cardiology, neonatal neurology, and the neonatal follow-up clinic. Children are seen starting very early on, and when they are done in the neonatal follow-up program at 36 months, they move up to psychology, and we continue to see them at regular intervals right up until they transition out of Sick Kids. So supporting them with that transition from high school to post-secondary education. And I think we're done. So thank you very much for your attention, and sorry about all the scheduling mix-ups today. Hopefully you have a break now.
Any final questions for Renee?
I should have put my email up, Cecilia, but I'm happy for people to send me questions or anything they'd like to know. So it's renee.sananis@sickkids.ca.
Thank you so much.
Thanks, Cecilia. Have a great weekend.
You too. Bye.